Yes, thank you, Pega. Thank you, Dr. Mavle. Good afternoon, everyone. So the speaker for our student presentation today is Alexandra Jimmer. She completed her BSc in Anatomy and Cell Biology, as well as her MSc in Family Medicine Research from McGill University. Prior to embarking on her medical school journey in 2016, she obtained her medical degree from St. George's University in 2020 and subsequently began her general surgery residency at SUNY Upstate Medical University in New York. She's currently a third year PhD student in the Department of Experimental Surgery at McGill University and is working in the lab of Division of Pediatric Surgery under the supervision of Dr. Pramod, Dr. Dan. Her research project is entitled Exploring Survival Morbidity and Quality of Life in Congenital Diaphragmatic Hernia. Her study is using a mixed methods of study design to demonstrate the impact of CDH, a rare birth defect, on the quality of life of patients with CDH neurodevelopmental impairment from their perspective. The voices of children and their families are rarely heard over the trajectory of their care. And while a few studies have superficially explored CDH morbidity and quality of life, no study to date has addressed survivor morbidity utilizing a qualitative methodology that focuses on the voices of patients' families during their medical journey, demonstrating the importance of her work. This project aims to describe the evolution of the disease for the patients with CDH and neurodevelopmental impairment and to demonstrate the impact of this condition on both patient and family quality of life. Alexandra, you may begin. The floor is yours.
Thank you so much. I'm just going to share my slides here. Fantastic. Thank you so much for the introduction and the opportunity to present our work. The work I'll be presenting today is the third and final piece of my PhD thesis and will be presented at the American Pediatric Surgical Association annual meeting this May. We conducted this research because the voices and perspectives of patients are rarely heard along their illness journey, limiting our understanding of their unique needs. And the importance of presenting this research today is because our results shed light on the lived experiences of CDH patients and their caregivers and offer insights that may inform strategies to better address their unique needs. We have no conflicts of interest to disclose. So for those of you who may be less familiar with congenital diaphragmatic hernia or CDH, it is a rare developmental anomaly of the diaphragm occurring in roughly 1 in every 2,500 to 4,000 live births. And when this failure of diaphragm formation occurs, it allows for herniation of the abdominal contents into the thoracic cavity during critical periods of fetal development. Ultimately, this impairs lung development and results in pulmonary hypertension. In addition to these effects on the pulmonary system, infants with CDH often suffer from multi-system morbidity that can affect their quality of life and have long-lasting impacts on both the patient and their family. Now, structured multidisciplinary long-term surveillance is critical for the early identification and mitigation of this morbidity. And long-term follow-up is likely even more crucial for those infants with neurodevelopmental impairment, or NDI, with up to 2/3 of CDH infants experiencing some form of neurodevelopmental or psychomotor delay by 3 years of age. And this results in increased care needs. However, despite understanding the importance of long-term follow-up in supporting patients and families, few studies to date have evaluated the impact of survivor morbidity on patients and their families. In addition, little is known about the lived experiences of families from their own perspective and the efficacy of these surveillance programs in actually meeting family support needs. This study aims to bridge this gap. The aim of the study was to explore the lived experience of CDH for patients and their primary caregivers, including those with NDI, and to explore the type and level of support they desire and need from the clinical team and community resources. We anticipated that patients with CDH and NDI and their families would face greater challenges and have more difficult lived experiences compared with CDH children without NDI. We conducted a cross-sectional qualitative descriptive study of the lived experience of CDH patients and their primary caregivers followed in our CDH long-term health surveillance clinic here at the Montreal Children's Hospital. The study period was from September 2023 to April 2024. Phase 1 involved a community consultation group interview with CDH families to explore themes related to the lived experience of CDH and to assist in the co-design of a moderator guide, which was used in the subsequent focus groups in Phase 2 of our research. Phase 2 involved focus groups of 3 to 8 participants, which included 3 to 4 patients and their primary caregivers. And participants were grouped according to time availability, language preference, the presence of NDI, and clinic graduate status. The community consultation and focus group sessions were audio recorded, transcribed, and translated into English when necessary. The transcripts were then subsequently analyzed using an inductive thematic analysis. 3 families, including 2 mothers and 2 fathers, participated in the community consultation session, and thematic analysis yielded 3 main themes. The first was parental anxiety and uncertainties. And despite relief that their child had survived the neonatal period, many parents expressed uncertainty with knowing if traits in their children could be attributable to their CDH. Parents also felt a strong desire to protect their children, which often led to parental anxiety. The second theme identified was lack of emotional support. The lack of emotional support available often led to frustration and isolation, resulting in all families expressing a desire to connect with other families. Lastly, the final theme identified was preoccupation of several families with the future. These families had difficulty finding information related to quality of life and what their child's future would look like beyond their surgical repair. All parents had a desire to learn more about their children's perception of their health from their own perspective and suggested asking children what they knew about their CDH, if they felt different from their friends because of their diagnosis, and if they were happy with the level of knowledge they had about their health or if they wished they could know more. Additionally, parents expressed the importance of speaking to a group of children of different ages with different severities of CDH in an attempt to shed light on how quality of life can range across the illness. Following the community consultation, we held focus groups with patients and their primary caregivers. A total of 26 participants contributed narratives regarding their lived experience of CDH in one of 4 focus groups or 2 individual interviews. This included 10 CDH children, 12 primary caregivers, and 4 young adult clinic graduates. Thematic analysis revealed 4 primary themes, which will be presented with illustrative quotes in the subsequent slides. Theme 1 was experiencing CDH as a caregiver. Fear and anxiety were common, especially in the early period surrounding diagnosis and birth, as parents were uncertain how their child would fare or if they would even survive to surgical repair. Theme 2 was experiencing CDH as a child. A common narrative to emerge among the children interviewed was the lack of lasting impact of their diagnosis, despite early challenges. Some children also discussed the lasting physical manifestations of their CDH, such as their scar. Interestingly, these children were not bothered by their physical appearance, and despite receiving questions from others related to their scar, did not experience ill intentions such as bullying. For those children who had graduated from the clinic, transition of care provoked fear and uncertainty. However, most revealed a positive and relatively seamless transition. This was in contrast to parents who continued to express fear related to the transition process and the ability of their child to access adult physicians with an understanding of their child's condition. Theme 3 was striving for normalcy. In terms of quality of life, both children and their primary caregivers expressed having an excellent quality of life despite early challenges. For those children with lasting neurodevelopmental deficits, while their parents may have expressed concern with their quality of life or what the future may hold, all children had a positive outlook, stating their quality of life was comparable to their peers, highlighting their resiliency. The last theme identified was getting the support we need. Similar to the results of our community consultation, many families expressed a desire to communicate with other families, stressing the importance of local support who could speak with the local context as opposed to national or international online support forums. Our findings provide evidence that despite persistent morbidity, particularly among children with NDI, most children with CDH perceive themselves as having a high quality of life with minimal residual deficits. In contrast, parents tend to experience significant psychological distress, particularly during the early postnatal period and the transition to adult care. Our study also indicates that in general, the resources both children and parents are satisfied with the resources provided by our institution, including our CDH long-term follow-up clinic. However, areas for improvement remain, including the need for enhanced parental support and the ability to interact with other CDH families, and more structured transitional care processes that actively involve both children and their families. The results of this study have suggested several areas for local quality improvement initiatives, such as the development of a local CDH family support network and the creation of a list of CDH families willing to engage with other CDH families. This study has also fostered an improved awareness of CDH family needs and has driven the addition of quality of life assessments to our regular CDH follow-up visits so that we can better assess how quality of life changes over the life course. Lastly, our findings have paved the way for future research efforts, such as the development of more formalized transition processes from pediatric to adult care, ensuring both patients and their parents are involved in the planning process, and the collection of CDH narratives from more diverse backgrounds to provide insights into how support services can be better tailored to meet the needs of a broader population. I'd like to take a moment to acknowledge my sources of funding without whom this work would not have been possible, and to thank my entire team for their guidance and mentorship throughout this important work. I'll open it up to questions now. Thank you.
Thank you, Alexandra. That was a great talk. I would like to remind everyone that you have to complete the evaluation forms that appear on the screen, and you may ask any questions that you might have.
Yeah, Alexandra, that's a wonderful talk. So what types of support did the families and children identify as most critical during their CDH journey?
That's a wonderful question. Thank you, Dr. Mwale. I think the most important aspect of support that appears to be missing in the care journey at this time is face-to-face interactions with other CDH families. And so what we know about this condition is that we now know quite a lot about the medical comorbidities, and we have enough data to support statistics on how children will do sort of quantitatively over the life course, but very little is known about how their quality of life is impacted and how this will change across their journey. And so parents really felt that something that was lacking was the ability to speak with other parents who had children with this diagnosis to really shed some light into how their journey had changed, from diagnosis to early childhood and throughout the process. And then additionally, one of the other things that came about was transition from pediatric to adult care. So we know in many chronic conditions that this continues to be an issue, that transitional period from pediatric care towards adult care is challenging. You go from a provider who's known, your child and all of their care needs for quite a long time to this abyss of adult care and not really having one person who's going to follow you consistently. And for parents to feel comfortable that their child is not only potentially leaving the home for the first time, but that they're going to have adequate medical care when they go up and embark on that journey.
Well, thank you.
Wonderful presentation. Don't mind if I ask a question? I was just wondering, what about, so you mentioned for interaction with other parents, which makes sense. How about like online social platforms and so on? Have you considered trying to maybe put together one of those for these families? And in that case, you're not just restricted to, let's say, local, right, access. You could go national, even international, depending on how big the group is, right?
Yeah, that's a great suggestion, Dr. Grant. And I think that from a local context, that perhaps might be something that is worth diving into, and certainly something that within our long-term follow-up clinic is really an avenue that's on the horizon for us is trying to provide this support to our families. There are online support forums, both with Facebook and some other more national and international groups that do exist, whether they be sort of like question and answer forums, chats, things like that. I think what's unique about the Quebec population is obviously we have, a bilingual population. The context is a little bit different than, perhaps what they're seeing. The biggest support groups would be out of Europe and the United States. And even just from a healthcare systems perspective, obviously that differs as well. And so I think we'd like to start small, really starting with the local context. And I think there's definitely an opportunity to build a program, perhaps nationally, and then even beyond that. So especially, in light of how we're using Zoom today and everyone's busy schedules, that may be, an opportunity to get families together instead of having them actually have to come and meet in person. It's a great idea.
For sure, no. The reason why I mentioned also internationally, because it depends on the family, right? If you have a cultural issue, because it locally might be really restricted, and maybe if there's one family that's not the same culture, it might be easier to ask out, get advice from another family of similar culture. In that case, you might have to branch out a little further than just that local. That's why.
No, that's great advice. I appreciate it. Thank you.
I think there's a question in the chat.
Yes, there's a question in the chat. It says, based on your research, what are the most common emotional and psychological struggles that family experience? And what are the most common long-term complications of the CDH survivors face?
Great questions. With regards to the emotional and psychological burdens and challenges that families face, I think that those really change throughout the life course. So initially, with the initial diagnosis, there's significant sort of fear and uncertainty that parents face. They really don't know how their child is going to fare. Frankly, they're not even certain that their child will survive the neonatal period and make it out of the hospital. These children are operated on early after birth, which can be quite challenging for parents that maybe they themselves have never gone through a surgery or they don't know anyone who's gone through a surgery. Also, the intense challenges of a family who have now just given birth themselves, and parents are already recovering themselves from that, and now they have to make medical decisions for their newborn. So I think that's part of it. And then that can also be exacerbated from parents, mothers who may be recovering in a different hospital actually than their child. They may be physically separated from their newborn who's in the NICU, but they can't stay with them. So that has some unique aspects of challenges. And then as things progress, there's new challenges that come out. And so I think with the uncertainty, there's a lot of blame and sort of fear that comes with that parents face. And then just the idea of every time that they go to the doctor, and there's fairly frequent visits in the first few years, never really knowing what to expect, not knowing if their child is going to have complications, if things are going to get better or worse. And that sort of dives into the complications that these children can face with regards to long-term morbidity. The most common would be respiratory impairments. And so because of the pressure that when the abdominal contents herniate into the chest during fetal development, it really compresses that lung that's supposed to be developing in that space. And so these children are born with sort of a small lung on that side that hasn't properly developed. And so they can face frequent respiratory infections, most commonly would have issues with asthma and exercise tolerance. Although generally this can be quite mild, in some children this can be pretty severe. And then there's always a risk that the hernia can recur. And so despite our best attempts at surgically correcting this, it can recur. And then because a child has gone through a surgery, another common complication that can occur is the possibility for bowel obstructions in the future. Just because of the scar tissue that develops. And so there's quite a host of issues that can happen over time.
Thank you for your answers. If there are no more questions, we would like to move on, and I would like to give the platform to Dr. Faxon Morley, our GPD.
Wonderful. Thank you so much for the opportunity to present my work.
Thank you very much, Alexandra. Really wonderful work. I look forward to the future of that work. Very nice. Yeah. So it's Today we have Dr. Kharma Foucher, who has an MD, PhD. She is the Associate Dean for Research in the College of Applied Health Sciences at the University of Illinois, Chicago, UIC, and Director of Education and Professional Development at the UIC Center for Clinical and Translational Science. A member of the UIC faculty since 2013, she is currently a full professor in the Department of Kinesiology and Nutrition, with courtesy appointments in the Departments of Biomedical Engineering and Physical Therapy. Professor Foucher and her SB, which basically stands for Scientia Baccalaureus, which is Latin basically for Bachelor of Science in Engineering Sciences from Harvard University, and both her MD and PhD in Bioengineering from UIC. She leads the Biomechanics and Clinical Outcomes Lab, where her research focuses on improving patient-centered outcomes in osteoarthritis and promoting equity in musculoskeletal healthcare. Beyond her work at UIC, Professor Foucher is an associate editor for the Journal of Biomechanical Engineering and a longtime faculty member for the Orthopedic Research Society, formerly the US-born and joint initiative, Young Investigator Initiative Grant Mentoring Workshops. She recently completed a term on the board of directors of the Orthopedic Research Society, where she served as chair of the Community Council. The title of her talk is Person-Centered Biomechanics, Approaches to Improve Physical Activity and Reduce Fall Risk in People with Osteoarthritis.
All right. Thank you. Thank you for the invitation, the introduction. It's great to be here, and I really want to thank Alexandra for your nice work. I had a friend in graduate school who had a baby with that condition, and thinking about back to what she went through, that really sheds new light for me on that experience. It also is a really wonderful segue into what I'm going to talk about. So completely different disease, but still very important to think about things from the perspective of the people who are going through it. So I'm going to tell you a tiny bit about me in the lab. I'll talk about osteoarthritis with this concept of osteoarthritis or OA as a disease of the whole person. Talk about our work with falls and physical activity, and then some closing thoughts. So even though this is particular to osteoarthritis, again, no matter what we're studying, what our disease is of interest, our patient population, I think I'd like to think there are some generalizable messages and lessons here. So I love the quote here is the reaction of my teenager when I dug out this old picture. So this is me at probably the age of 4 or 5, so happy to have gotten a globe from Santa. So he said, "Oh, so you were always a nerd." Like, it explained so much. But even though I had this interest in the whole world, my professional journey has taken me just from Chicago to Boston and back. So I did my undergrad in engineering. I came back to my hometown of Chicago for graduate studies in my first faculty position. And I was delighted to have the opportunity to come back to University of Illinois, Chicago, where I have been since 2013. So osteoarthritis. Osteoarthritis is sometimes talked about as a wear and tear disease or a degenerative joint disease, although there's a big initiative right now to try to find better language to describe it. But for anyone who has family members or they themselves have had osteoarthritis, you might hear about it talked about as bone on bone or wear and tear or something of that nature. Um, the image comes from quintessential photos, radiographs of the 4 stages of osteoarthritis. Here you can see the hip joint going from maybe a little bit of narrowing, particularly in this area, some sclerotic bone, to more moderate disease where you really see osteophytes, you see a lot of morphological changes and significant joint narrowing, joint space narrowing, even on a plain radiograph. So about 2012, you really started hearing people talk about this as a disease of the whole joint. The earliest reference I found to that phrase is from about 2012. Meaning that instead of just thinking about it as a cartilage disease or as cartilage narrowing, we should really recognize and think more comprehensively about how osteoarthritis affects all of these tissues of the joint. So not just cartilage, not just inflammation, not just mechanobiology, not just joint level biomechanics like what I study, um, really the whole entire joint. And really, my what I'm trying to kind of convey is not just the joint. So to do this, I've been really over the past like 10 years or so thinking about the World Health Organization International Classification of Functioning Disability and Health, which, if you're not familiar with it, is a framework for describing, classifying, understanding health and health outcomes. So thinking about osteoarthritis and using this framework, which on the orthopedic side, we don't do so much of, osteoarthritis really affects body structures and functions. That part we do think about all the time. So structures include all the structures of the joint, the tissues of the joint that you see in this diagram. Functions, one of the main functions would be pain-free mobility. But looking at the other boxes, so osteoarthritis also affects activity and participation. So activity limitations in the ICF framework are difficulties executing tasks or activities like seeing, hearing, and walking. Now we know that osteoarthritis is associated with characteristic changes in gait mechanics that I've thought about day in and day out for the last 25 years. We also see participation restrictions. So these are defined as problems that someone may experience in everyday life situations. So the one that I'm going to be talking about would be physical activity. So the OAI is a gigantic cohort study pertaining to osteoarthritis. And a fairly recent report reported that half of men and 80% of women in that cohort do not meet physical activity guidelines. Additionally, 14% of people with osteoarthritis are unable to work. Now, there are also environmental factors and personal factors involved. So these are defined as the physical, social, and attitudinal environment in which people live and conduct their lives. And these environmental factors include products and technology. So some of the personal factors involved that can affect your experience with osteoarthritis might be age, I'll talk about sex and gender, race and ethnicity, among others. Environmental factors, in addition to the built environment, can include arthroplasty itself, as well as access to arthroplasty and access to other treatments, assistive devices, etc. So our first challenge then is to redefine the way that we think of osteoarthritis from a joint disease to a disease of the whole person. And I would invite whatever it is that that you study within the audience here, think about where your research fits in this framework. So in orthopedics, we're often really thinking about body structures and functions, but I like to try to have a more comprehensive understanding. The second challenge is to do patient-centered research. So there are two kind of frameworks for thinking about how we conduct our research. So the medical model and the person-centered model. Now, my assertion is not that the person-centered model is the best. Kind of a variety of viewpoints are needed, but I just want to highlight this framework. So, whereas the medical model might focus research questions on the attributes of the disease, the person-centered model focuses on the attributes of the patient. In the medical model, we might be prioritizing problems important to physicians and regulators. So in our healthcare context, bundled payments and the way that surgery is reimbursed is very relevant. So we might think about what we can do to improve the value of the care, to reduce some of these outcomes that are scrutinized. The person-centered model focuses on problems that are important to the people with the disease. In the medical model, patient preferences may not be formally considered, but they are explicitly incorporated in a person-centered model. And the ones that I think are the most interesting probably right now, instead of seeking to improve outcomes for an average patient, having your results be generalizable and thinking about a bench to bedside approach. In a person-centered model, we're thinking about the individual patient, how to improve outcomes for the individual patient. How might your results, instead of thinking about your results being generalizable, how might they be individualizable? How might you adapt it to an individual person situation? And thinking about our questions and our answers, reversing that flow. So instead of thinking from bringing our findings from the bench to the bedside, what about thinking about the bedside to the bench? So what does this look like in my case? So I am an engineer by training, but I've really been intentionally over the last 15 years-ish to change my thinking, to flip my framework to use biomedical engineering to address person-oriented outcomes. So the first example of this, the first kind of research bucket of mine is falls. So some of the factors that are associated with osteoarthritis include age, obesity, muscle weakness. We have gait changes. People slow down, right? People slow down. People change the way they walk. intentionally and unintentionally. There's pain, obviously. That's the most prominent, most bothersome symptom in many cases. And we have other issues like impaired proprioception. So it turns out that these are also pretty much the same factors that are associated with falls. So a former grad student that came through our group did a review a bunch of years ago now, where she looked at this overlap between fall risk factors and osteoarthritis risk factors and really found a lot of similarities, raising the question, well, I don't want to get ahead of myself. I can go on a tangent, but I won't right now. So refocusing. So another reason I really enjoyed Alexandra's presentation was because we've started to delve into some qualitative approaches and using these research methods to motivate our biomechanics research. So what are the problems that we should be studying? So in this particular study, this was my first foray into qualitative methods. We wanted to find out what the fall experience was from the patient's perspective. We wanted to get a group that was diverse with respect to gender, age, affected joint. Many of our biomechanics studies, we try to find a really narrow, like clean group, only unilateral knee OA with no other problems. In this case, and in some of my more recent studies, we're really trying to get a more representative participant group. We held focus groups with open-ended questions pertaining to the circumstances and consequences of falls, and analyzed transcripts for themes, and continued until we reached thematic saturation. So I'm just going to share a couple of the themes and a couple of relevant quotes. So first, the circumstances of falls. So the quote that I'm highlighting is, it's usually when I'm walking. So when do people fall? Most falls are associated with trips or slips. Most falls happen during walking. This is important because we need to know when the falls are happening, what's going on in that situation, so that we know how to intervene. So very dramatic stories. There's a quote that I didn't include in this talk about falling in a work situation and having their lunch fly everywhere. Carrying something, someone fell from a ladder. One of the participants had a memorable fall while biking. Next, people are really limiting their activity. So slowing down, keeping on one level of the house. So someone might, if they have a two-story home, really try to keep all their activities on one level so that they only have to do the stairs once a day. So luckily, you can actually learn how not to fall. So this video is from my colleague and now collaborator, where using a treadmill to simulate a trip, tripping over and encountering an obstacle, you can learn to recover. So not every trip results in a fall. You basically walk it off. So you learn how to limit your trunk flexion. I'm going to pause this. Limit your trunk flexion, slow down your trunk, and even kind of pull it back after you've hit that obstacle. But you have to do it fast, and you have to do it automatically without, the consciously thinking about it. So those strategies, those biomechanical strategies that make you recover versus hit the ground, they get better with practice, like any other motor skill. So this is an example of 20 perturbations, 20 treadmill perturbations in a row for one participant, and their trunk flexion angle. So how much their forward, their trunk is positioned forward at the time that they would be recovering, have that recovery step. And you can see that with repeated exposures, the trunk angle goes from 40 degrees of flexion down to like the 15 to 20 zone, which is more conducive to recovering instead of falling. So we wanted to try this with people with osteoarthritis. So in a pilot study, we recruited 17 women with knee OA, mostly from the UIC community, and 22 asymptomatic women. They all had 20 exposures to a treadmill simulation that was not as intense as that giant one that you saw in those videos. And then we looked at pre and post, how they responded to one of those bigger perturbations of a magnitude that would simulate a trip. So we found that the training does work almost as well as in controls. So the training does successfully reduce both the trunk flexion angle and the trunk angular velocity. In some cases, ideally going from that forward motion to more of a pulling up. And you see that in both the control group and the group with osteoarthritis. So moving to kind of transitioning to physical activity, another quote that I found very impactful was, I was a very, very active person, and now I find myself not wanting to do anything because I'm so afraid of falling. So another theme was that people are very much kind of gradually pulling out of their everyday routines, their normal levels of physical activity in in the focus group. So the second set of studies that I want to give you an overview of involves physical inactivity in osteoarthritis. So from this and another review article, we've learned that behavior-based interventions alone don't work. So they don't work very well. It's not really just a matter of building your tolerance to the pain, building your coping skills. So in this line of work, I really wanted to get to the root cause of this activity limitation, hypothesizing that there were OA specific and OA biomechanics specific reasons why people were unable to adequately respond to physical activity interventions. So the first model, borrowed from the older adult literature, is this energetic pathway to mobility loss, where gait inefficiency can lead to having less energy left over, which makes you more tired and causes you to lower your activity levels. So in this marble analogy, a young adult might have a larger jar representing their total capacity, and they're not using as much of that jar space for the marbles, which is the energy that they need to use for walking and other everyday activities. The older adult, smaller jar and more marbles. in osteoarthritis, I'm really interested in hip abductor weakness. People with weak abductors may tend to compensate with excessive trunk motion, which is energetically costly and can get you in this jar situation. An adaptation of this model for older adults with chronic pain was published in 2018. And that has this extra bit where the pain experience directly impacts the energy cost of walking. The second model, the second framework that I use is the activity avoidance model. And this is specific to people with osteoarthritis, whereas the previous model was something developed for older adults. So in this model, pain and psychological distress, such as fatigue or depression, which are prominent in osteoarthritis, lead a person to avoid some activities, exacerbating muscle weakness, making them less able to be physically active. And you can see some of these arrows are going in both directions. So putting these all together is quite a mess of spaghetti. But the main idea, the main crux of it is this connection between abductor strength, gait inefficiency, and physical activity in the context of pain and fatigue, as well as kinesiophobia. So in a series of studies, we've looked at 37 women with hip OA, 26 women and 17 men with knee OA in two separate studies. We asked them various questions about falls, other joint problems. They completed a battery of surveys, including the HOOS and KOOS, which are common osteoarthritis survey instruments. We did full gait analysis with monitoring the oxygen consumption during walking. And we did strength testing. My focus for this was the abductors. We also tested a couple other muscle groups. And they completed performance tests and had their activity monitored with actigraphs. So for this part of my talk, really just focusing on the specific variables in that model. So the findings, these are mostly true. This model, we've published a lot looking at this in different ways, kind of following along this cycle. Just a brief excerpt of these outcomes. Abductor weakness, not associated with gait efficiency in this particular group of participants. So this scatter plot, peak isometric abductor torque versus how much of the total energy capacity they're using for walking. You've never seen a more random scatter plot in your life. Gait inefficiency, though, was associated with less physical activity. So this is a self-reported measure of physical activity called the UCLA score that captures aspects of quantity and intensity. And again, on the x-axis, we're looking at how much of that total energy capacity is being used for walking. So we found a moderate, not earth-shattering, but moderate correlation here, enough to intrigue us and make us want to do more. Similarly, abductor weakness. Oh, this is the wrong scatter plot. You can use your imagination. It looks similar, but the correlation is a little bit stronger. Abductor weakness also associated with less physical activity. And this is something that we've also seen in people after they've had a total hip replacement. But now the elephants in the room, so we've got that middle part, down, but the elephants in the room are pain and fatigue. So again, what's going on with the patients? We also have fear. So fear was a prominent theme that came up in the focus group study, and kinesiophobia, or the fear of movement, is a big deal in osteoarthritis, a big reason that people restrict their behavior. So we did see, again, this moderate association between pain scores and the energy cost of walking. So we're looking at oxygen consumption per unit distance on the y-axis, with pain scores going from more pain to less pain. And this this supports this premise A in this pain energy concept. So again, moderate correlation, but interesting. We also see the hypothesized relationships between activity level and pain, activity level and kinesiophobia, activity level and fatigue scores, both self-reported fatigue, amount of fatigue, and fatigability, which is movement-associated fatigue. All of these characteristics, all of these factors were associated with being less physically active. If you throw them in a regression model and see what sticks, like, I'm being a little bit flippant, that's not exactly what we did, but basically, together, these factors get you over 50% of the variance in physical activity. So this is before we even touch any kind of behavior. We also don't have the actual gait compensations in this model at this time. But really, this was really encouraging to me. Like, there's something to this, I think. Um, who cares if they're not modifiable? So are they modifiable? Yeah, I think so. So aerobic capacity is associated with fatigability. So you can think about um, expanding their fitness, like increasing the size of that energy jar. This has been used in people with spinal cord injuries and possibly MS. But it's been used in other populations, so we think that that might be a promising approach. And we've also done a pilot study with split belt treadmill training, where someone walks on a treadmill with two belts, where one is going at half the speed as the other. So when you do that, you adapt to change your step length to compensate. So by doing that, you will adapt a more symmetric gait pattern that leads you to use less oxygen when you're walking. So it's improving energy use and it's improving propulsion, which apparently I don't have here, but it is one way to exploit biomechanics to get at those energy outcomes. And this was just a single visit. In stroke rehabilitation, these types of interventions are used a little bit more commonly over a longer term. So this adaptation is potentially trainable. So getting at that root cause is something that I am encouraged that we can do, and we can develop interventions that either can sufficiently improve physical activity based on being having the person more physically capable of being physically active despite their osteoarthritis. And behavior-based interventions do have a role, but perhaps we can optimize people before they encounter those interventions. So to summarize, we've looked at several approaches. This is kind of our current status from that initial spaghetti figure, whereby we might be able to improve physical activity. But physical activity and falls really go hand in hand. So as I transition to some closing ideas, we did ask those physical activity study participants if they had experienced a fall. And about 30% of them said yes. Referring back to the focus group, participants really linked that idea of being afraid to fall, not exercising, feeling weak in that cycle. But on the other hand, I think it's important to recognize that in these folks with osteoarthritis, we're really looking at this top scenario, falling off a bike. One of the participants, focus group participants, was still an avid runner, but found herself tripping on uneven pavement. In fact, the fallers in the physical activity studies had better function, less pain, and were more physically active. So it might be that they have more opportunities to fall. They're exposing themselves to more chances to hit an obstacle. But what this also means, and what I'd like to emphasize, is that osteoarthritis, we talked earlier about a bunch of things that it's not just. Um, a lot of what we think we know about OA and falls, for example, comes out of aging. But most of these people are not actually older adults. In and most of them are not classified as obese necessarily. Middle-aged people with osteoarthritis fall at higher rates than older adults, right? So this is not an aging problem in this group. Most of our participants were middle-aged, with a few even below what you would consider middle-aged. And the older adults in our group, they were not weaker or fell more. They actually were less fearful, less fatigued, less fatigable. So there's something going on beyond just aging. And I think we need to expand the way that we're thinking about osteoarthritis to get at some of these important factors. Clinically, no one's asking them. That was another big finding from the focus group study. One of them said that they have a don't ask, don't tell policy with their physician. And why? Because they feel old. Um, it's causing them considerable psychological distress. They don't want to kind of deal with falls as a problem because that's for old people. That's the way their clinicians are approaching it as well. Um, so this top quote, um, I didn't label them, so I can't remember which quote or both of them was from this person, but one of the it's in the paper. One of the focus group participants was a young mom, like in her late 30s, former college athlete, um, and feeling like an elderly person um, was a theme that came up again and again in her group and in the other groups. It also matters because um, there are comorbidities that osteoarthritis puts you at higher risk for. Physical activity reduces the risk of these comorbidities. If we're not addressing the OA specific issues, we're missing out on opportunities to improve care and improve these lifelong outcomes. You might not be old when you get your osteoarthritis diagnosis, but hopefully you become a healthy older adult with none of these conditions. So I think it's important for us to think about them in their proper context. So wrapping it up, tying a bow on it, osteoarthritis is a disease of the whole person. And again, whatever you study or whatever type of patient you care for, I think these are generalizable and individualizable to your research points. So thinking about centering what the whole person needs, knowing where you are on that ICF framework, all of the boxes are critically important. All of the levels, the tissue level, the cell level, the whole joint level, those are all important. But I think it's important to realize where you are in that big picture. Are you studying what your target population needs you to be studying? And are you accidentally making assumptions that can lead you down the wrong path? Another example, a quick example of that was we did a completely separate study back when I was a postdoc, that where the assumption baked in was that people who were no longer in the workforce would be less active than people that were in the workforce. So trying to recruit a younger, not retired population. And this was just in the back of my mind at the time, but my retired mother-in-law was walking 2-3 miles a day, way more active in the garden, and I was sitting at a desk for most of the day. So that was kind of one of the early things that got me thinking, are we thinking about this in the right way? So with that, I would like to acknowledge our funding sources. And thank the ever-growing list of trainees and collaborators who have contributed to this work. And thank you all for your attention. And I hope we have time for a little bit of discussion. Thank you.
Yes, we do. Thank you very much for that really wonderful presentation. We have a couple of questions in the chat. Perhaps I'll ask the people to ask it themselves.
I'm going to.
Fatima?
Hello, thank you. Very great presentation. My question was, is the study focusing in patients or people with the early stage of O8 or advanced stage?
So, yeah. So for the purpose of the talk, I put several things together. For the actually for both the focus group study, the pilot study on the fall intervention, and the physical activity studies, we wanted to get like a wide range of severities. So we didn't really group people or screen people. There was no inclusion or exclusion criteria about having a certain amount of pain, like in some of maybe my previous work. So really trying to get that whole span. And I see you also asked a question about selecting women. So that was also kind of an accident of fate. So
Mhm.
one of the grants that supported the work was targeted to women. So that's why in that study, we had only women. And so the way that I synthesized the data for the purpose of the talk, I put the women from the NEOA study, which was a co-ed study, together with the women from the HIPOA study. Before doing that, I looked at whether there were what differences there were by joint. So actually, people with hip OA and knee OA have weak hip abductors. In these groups, the pain scores were comparable. There weren't any significant differences with any of those constructs. So the findings do hold up basically whichever way you slice and dice it. So um, the short answer to the question is because of the funding source. But the findings are, I believe, robust to both men and women.
Rashid? Rashid says, great presentation. I just wonder if having OA arthritis in two different joints, like hip and knee, and their associated limitations was assessed in comparison to people with involvement of one site.
So yes, in one of the dissertations that came out of this, I cannot remember whether there were differences. From my best recollection, so most people in the study had osteoarthritis in more than one joint, um, which I understand is clinically more typical. Um, I've done other studies in the past where, again, I was looking for that pristine patient population. That population doesn't exist. So as far as I can recall, there were not major differences, but that is definitely don't quote me on it, more work is needed. Um, that's a great question, and in a larger study, it would be great to look at whether kind of that accumulation, that progression, that addition of joint to joint to joint decreases physical activity for people.
So Marianne says, was it difficult to make the participants do physical activity even when they have pain?
Yes.
Yeah, so I I think the question might be like participating in the physical activity required for the study itself. Um, so because for these were observational studies except for the pilot treadmill study. Um, no, so the types of activities that we do in our lab right now for these studies, participants can do them if there are certain tests that they need to opt out of, they can opt out. Everyone, we have not had any dropouts with this protocol on the the walking test, the biomechanics part. People are able to walk at their own pace. So in our study designs, we don't control the speed. We allow the patients to walk at a self-selected speed and we adjust for it. Either statistically if it's relevant to do so or in other ways. So I guess to answer the direct question, no, but everyone knows that they're able to rest at any time. that they're able to opt out of anything. You know, the informed consent process takes place throughout the entire protocol, right? So if people are having difficulty, we try to really make it clear that their safety, their comfort is paramount. Which is important because actually some people try to push themselves, right? Um, uh, I did a study like way back when, and people where we put activity monitors on people the day after their gait test. Um, People walk faster in the lab um, than they do in the community. Um, and it's what is the word? It starts with an H, the something effect. Um, so there's a psychological effect where people try to look good, try to do better in that test situation. The act of observing something changes how you do the thing. But people with osteoarthritis are not able to walk as much faster as controls do. So even though they are still bumping up their speed, um, those OA specific limitations are limiting the amount that they can do that. So it's not difficult to make them do the activities. Sometimes it's difficult to keep them from overdoing it.
So there's a question from Mohan. Great presentation. I would like to know if you have looked into how assistive tools like walking sticks or braces affect not just mobility, but also pain perception and muscle weakness over time.
Oh, I'm starving.
That's a um, that's a great question, and with a nice short answer, which is no. I have not looked at that in my work. Um, Anecdotally, with braces, though, um, I think that there are some issues sometimes with people wearing them often enough to get the effect. Um, but yeah, you know what? I'm gonna just keep it to the no because I have not formally studied that, and that was the question that you asked.
Yeah. Excellent presentation, Kama. I really loved it. I was curious about the energetic pathway. So, in your view, where is the point of no return in the energetic pathway?
The Hawthorne effect, sorry. Yes, the Hawthorne effect. Thank you. That is I'll come back to that question in a second. That's the term for when you are observing someone doing a task, the way that they do the task changes just from observing it. Thank you. I knew it started with an H. So where's the point of no return? That is a great question that I have not thought about. So I guess embedded in the question is that, like, if we use the jar metaphor, maybe is there at some point you can't take any more marbles out, or the jar can't be expanded? I don't know. I would think that um, it that's so interesting. I'm going to be thinking on this. Um, you probably have the aging situation, right? And you have the osteoarthritis, and I'm visualizing maybe there's a point kind of at which they cross or merge or meet up, and maybe that is your point of no return. Um, yeah, I'll have to think about the extent to which there is one and how we would identify if someone's met it.
Yes, because you present a wonderful concept that OA is, it's not just a disease of the joint; it's a whole person, and you also present the psychological part of it. Is it a point? Because in OA, you also have muscle mass that you have muscle mass that significantly declines, and you also pointed, to a point where maybe the patients have some psychological withdrawal, and because you presented at the beginning those nights as they are falling. So at what point do we intervene to prevent so that it's an irreversible mobility loss during the energetic pathway? It is really, really fascinating.
Yeah, I think that goes back to where, if you think about like the big spaghetti diagram with all the crossing arrows, where is that individual person? Where are they sitting at this point in time when you encounter them clinically? Where are they? Um, so for some people, um, maybe the loss of muscle mass might be too much to start recovering. But maybe you can intervene at another part of the diagram, on that psychological aspect, or give them an assistive device that gives them a little more confidence. Um, Maybe the energy part, maybe they can't tolerate an aerobic intervention. So maybe in that case, you concentrate on, there's ways that you can improve the efficiency of the gait, without causing them more physical pain. So maybe you focus on gait retraining with limiting their trunk motion. Um, so as I think about your question and think about, that overall context and that idea of individualization, um, maybe it doesn't matter, right? Maybe, if you're beyond, the point of no return in one part of that, you have some room in some of the other parts. So important to understand that there are all these intersecting pieces.
Yeah. And also, as you were talking, I was thinking, do you see the energetic pathway as specific to OA, or is it part of a broader mechanism seen in other chronic musculoskeletal or inflammatory diseases? Um,
Yeah. So the energetic pathway, that portion of the model, that comes from the aging literature. So that is not specific to musculoskeletal conditions at all. Um, and in fact, so one of like the worries, right, was that it wouldn't be applicable because these patients aren't in the age group where those researchers developed this framework, this model. Um, so it's, I think it's broadly applicable, but the way that it turned out that the way that I was originally assessing fatigability, for example, I was using something that had been used in older adults, and that stimulus was not making them tired. So even though the the overall model seems to be applicable, the way that you evaluate it, the way that you intervene, the way that you assess, might be specific to the population that you're looking at.
right. So this last question alludes to, Marianne alluded to it. So how can we differentiate between inactivity that is caused by mechanical joint pain versus fatigue, for example?
That is a wonderful question. Maybe that's my next study.
Or
I don't know. So I don't, um, maybe it's even different for the same person at different times of the day. Wait, am I frozen? Okay.
No.
He's frozen though, right?
Yep.
I'll tell everyone else. It's so I love that question, but I think it maybe will depend on the person, it could even depend on the day. There's a series of nice studies looking at that trajectory, even with oh, he's completely gone now, right? The trajectory of pain and fatigue, specifically, how they relate to each other, and throughout the day, how they impact each other. So I think the picture would be complicated, but it would be I am really now highly motivated to try to think about how you would assess for an individual person what their biggest problem is, what is on the individual level where those obstacles are. So thank you for the question.
Nice. Mike?
Yes, wonderful, very wonderful presentation and very informative and very much a lot to think about for as I get older, what to do maybe to help if I land into this situation. Uh, Question was, you kind of alluded to it earlier, was on the grade. So you made it clear, I guess, that you didn't stratify based on grade of OA, but I was wondering if you had any plans on doing that since like early intervention and certainly activity training when you're not as maybe age related fatigue or maybe that would help for as you you know get further into the osteoarthritis pathway.
Yeah, so I have a couple of soapboxes related to that question that I could stand on. Um, I so for me, okay, so clinically, the main thing would be that you're gonna meet your patient where they are. So someone is not necessarily going to come to see you when they're at an early disease stage because they might not even know. They might have even as an individual, like you have your intermittent pain, you have your like activity related pain, and as an individual, like we know that that along the OA disease course, that's going to transition at some point into a chronic pain situation. Um, you can't feel when that is for you as an individual person. Like that's not something that you can predict. So one of the reasons why I don't, in the way that I frame my questions and plan my studies, I don't think a lot about either structural disease like KL grade, um, or really even um, chunking people by pain levels, is because um, at the end of the day, the person is going to be how they are. Um, so. Even though it causes a lot of consternation for some of my students, I do like to have these really messy study groups with limited information about like, I kind of have like on principle, I won't get x-rays unless there's like really, 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 really a reason to. The rheumatologist that we collaborate with, using KL grade clinically is not really something that any of the rheumatologists that I've collaborated with would be doing. You're treating the patient in front of you. So yeah, that is kind of a hill I will die on.
And how about patients on different medications? Do you see differences in how they respond then?
Yeah, um so we don't have enough of a sample size to tease that out yet for these studies. It is something that that's been on my mind, especially with still a lot of overprescription of like opioid painkillers in osteoarthritis, at least here. So yeah, the short answer is I don't know. When we're thinking about balance and falls, we're also thinking about blood pressure meds, depression meds. So yeah, medication is a whole can of worms that I can't speak to at this time, but for sure, as we're doing bigger studies, we can at least collect the information and then see.
Mhm. Okay. Well, thank you.
Thank you very much, Professor Foucher, for that really wonderful presentation. And thank you, Alexandra, and thank you everyone for participating in this seminar. Have a wonderful week, everyone.
All right, thank you again. Thanks
Yeah.
for the great conversation, everyone.
Yeah,
Thank you.
bye.
Bye.
Bye. Thanks for joining us.